بسم الله الرحمن الرحيم. نبتدي النهارده فعاليات اليوم الثاني لمؤتمر جمعية حديث الولادة والتعليم الطبي المستمر لجامعة عين شمس. يشرفني يبقى قاعد معايا على المنصة أختين عزيزتين عليا وشركاء في كفاح طويل ومجهودات كثيرة سواء في جناحي حديث الولادة في جامعة عين شمس، ألا وهو محضن الأطفال ومحضن النساء، الأخت الدكتورة صفاء شفيق إمام والأخت الدكتورة نيرة لا عارف نيرة إسماعيل. شركاء في رحلة طويلة خالص ونعمة الزمالة ونعمة الصداقة ونعمة الصحبة. شرف كبير ليا وشرف كبير انه ابتدي بابن من ابنائنا الدكتور يوسف حشمت يبتدي يقدم لنا يعمل لنا كيس برزنتيشن. الشباب اللي جايين دول عليكم مهمة كبيرة، عليكم مهمة كبيرة. احنا we fight it. انتم مش هتتخيلوا how much we fight it. how much we fight it عشان يبقى في تخصص اسمه حديث الولادة في جامعة عين شمس. how much we fight it. we initiated neonatal ventilation في جمهورية مصر العربية. we initiated. احنا أول مركز في جمهورية مصر العربية يبتدي neonatal ventilation. we taught جمهورية مصر العربية الهاي فريكونسي ventilation. we taught it. ده بردن علينا، دي مسؤولية عليكم انكم تكملوها وان شاء الله تبقوا قدها وقدوها. اتفضل الدكتور يوسف.
Thank you, Professor Hisham. It's an honor to be here to present a simple case yet and a very important one about neonatal hypoglycemia. We'll start with a personal history. Mariam Nadi Saad, she's now 25 days old. She was full term, 39 weeks, 6th order of birth of remote consanguineous parents. The complaint in this case was she had convulsions, attack of convulsions 8 hours post-delivery. The family history, we had remote consanguinity. There was no history of congenital anomalies or inborn error of metabolism, no history of diabetes mellitus in the family, or no neonatal ICU admission of symptoms. The perinatal history of this case, prenatal, the mother had no diabetes or preeclampsia, has no history of infections, no irradiation exposure or teratogenic drug intake. Natally, it was delivered by normal vaginal delivery, although the patient weighted 4.3 kilograms, it was non-obstructed labor. It was at hospital, the upper score was 8 at 1 minute and 9 at 5 minutes. Postnatally, she had an attack of convulsion started 8 hours after delivery. History of present illness, the condition started 8 hours post-delivery when the patient, she was sent home about 4 hours after delivery. It was vaginal delivery. 4 hours after she went home, she developed attack of GTC about for 2 minutes. We have no available data from the hospital about if random blood sugar screening was done after birth or not. At nearby hospital, she was hypoglycemic. The random blood sugar was 20 ml per deciliter. She was given their IV shot of glucose 10%, admitted on IV fluids in a peripheral cannula, then referred to our neonatal ICU on the next day. The convulsions didn't recur till referral. It was only one time. On admission at our neonatal ICU, she was fair general condition. CNS-wise, she was irritable, jittery. There was mild hypotonia, but fontanelles were at level, and the neonatal reflexes were intact. Cardiovascular, the normal S1, S2 was no murmur heard. The perfusion was 2 seconds. Just bilateral equal air entry was no adventitious sound. Abdomen, legs, no organomegaly found, no omphalocele, and with normal intestinal sounds. Other examination, the head, neck, and extremities examination showed no apparent congenital anomalies or abnormal physical features like hemihypertrophy. On admission, the random blood sugar was 27 milligram per deciliter. This was the blood random blood sugar. She was referred on IV fluids. While referral, she was on IV fluids with an GIR 6 milligram per kg per minute. So what we did, because she was symptomatic, she has jitteriness and on 27 milligram per deciliter. So immediately we give 20 milligrams per kg of IV dextrose 10% was given, which is equivalent to 2 milliliter per kg of dextrose 10%. The random blood sugar was followed up every 20 to 30 minutes till it reached a safe level above 45 milligram per deciliter. Then hourly, we of course started IV fluids. GR started at 8 milligram per kg per minute because she was on 6 on admission and she had an hypoglycemia, which was increased gradually guided by the random blood sugar till we reached 15 milligram per kg per minute to achieve random blood sugar above 45. Of course, after insertion of central cannula, UVC to give high concentration of glucose. Then we started feeding gradually while decreasing IV fluids till we reached full oral intake. But regarding, she was given Ducal to support the caloric intake because she still had an attacks of hypoglycemia. So we give Ducal, and even on Ducal, she and full oral intake, she had an attacks of hypoglycemia which needed giving IV glucose shots. Till the 4th day, we still have an attack of hypoglycemia, so critical sample was withdrawn while the patient was on an attack of hypoglycemia, and urine sample done revealed that there was no ketone bodies. So at this point, our differential diagnosis went with either it's a case of hyperinsulinemia or a case of fatty acid oxidation defect. So we are asking ourselves here, it's a benign type of hypoglycemia that the brain has alternative fuel for energy. The answer here is unfortunately no, because the brain can only utilize either glucose or ketones for energy, and this baby has hypoketotic hypoglycemia. So it's a serious hypoglycemia, and that may cause brain injury if didn't corrected rapidly, because we don't have here glucose for an energy or even ketone for an energy. Her laboratory investigations done was CBC was normal. There was no abnormality. Total count was 16, hemoglobin 14, and platelets 354. CRP was negative. We ruled for ruling out sepsis. It was 2.3, which is negative. Creatinine was fine, 0.3, BUN 16, LT12, ST24. Serum electrolytes was normal. Sodium 136, potassium 3.9. And calcium total 9.7, ionized 1.2, magnesium 2.2, phosphorus 4.7. And as we already mentioned, that urine analysis showed no ketone bodies. So we got the results of the critical serum sample we sent. The glucose was 28 milligram per deciliter. The insulin was 60.6 micro international unit per milli, which is high. The normal range from 2 to 25. The C-peptide was 11 nanogram per milli, which is also high. Range from 1.1 to 4.4. The growth hormone was 8.4 nanogram per milli, which is normal. Beta hydroxybutyric acid was low, 0.015, and the range millimole per liter, and the range was from 0.024 to 0.0293. The serum cortisol level was 14 microgram per deciliter, which is in the normal level from 3.1 to 16.7. Serum ammonia was 119, serum lactate was 8, and lastly, the AMS was normal. Radiological examination were all normal, transcranial was normal, pelvic abdominal was normal, and echo done was normal. Since we had high insulin level, so we started, we think to start the drug treatment of hyperinsulinemic hypoglycemia. We started a diazoxide drug, which we'll talk on in a few minutes. But this is a specific ATP-sensitive potassium channel agonist of the pancreatic beta cells. Unfortunately, this drug is not present here in Egypt. What we had it from outside, so we started. Starting dose was 5 milligram per kg per day. We increased the dose up to 15 milligram per kg per day, but there was no improvement, marked improvement of the random blood sugar values. So we started sandostatin, octreotide, started IV on 5 microgram per kg per day, with increasing doses up to 20 microgram per kg per dose with marked improvement, but on high dose. About the marked improvement appeared on the high dose, which is 20 microgram per kg per day. So the patient, our patient was discharged on sandostatin 5 micro per kg 4 times per day subcutaneous with good oral intake with caloric supplementation with Ducal after referral to the endocrinology clinic and instructing the mother how to give sandostatin and measuring a random blood sugar at home. So if this was the role of surgery in this case, the role of surgery in this, there was no role of surgery in this case because the role of surgery done, which is subtotal versus partial pancreatectomy, and if you find a cause, focal cause, we do partial pancreatectomy. It's a diffuse cause, we cause subtotal pancreatectomy. It was indicated if we had refractory cases to maximal doses of medical treatment, which means that we still need to infuse IV glucose regarding maximal doses of medical treatment, or if we found like a local hyperplasia or like in selenoma in the beta cell of the pancreas, which is diagnosed by either fluoro-L-dopa positron emission tomography, PET scan, or by MRI. So in this case, there was no role of surgery. This is an algorithm for hypoglycemia, which will take rapidly. Professor Maha will talk in this thoroughly. But when I have an hypoglycemic patient, first to do if after the 2 or 3 days still hypoglycemic, we do if there is ketone bodies, I will do ketone bodies in the urine. If the ketone bodies was absent, I will do urine glucose reducing substance if it present. So I think of hereditary fructose intolerance or galactosemia. If urinary non-glucose reducing substance was absent in urine, serum insulin was elevated. If it was above 5 to 10 microunits per ml, we can do fasting glucose level. And it's not done so much here to diagnose, make sure that diagnosis is hyperinsulinemia. If the serum insulin level was above 100 microunit per ml, we'll do C-peptide to know if it's like endogenous insulin or exogenous. If the C-peptide was high, like in this case, so it's insulinoma. If it was low, so it's exogenous insulin. If the serum insulin was not elevated, so we are thinking here of a fatty acid oxidation defect or carnitine defect. If the ketone bodies was present, there was in the urine sample not absent. So we do growth hormone cortisol level. If the growth hormone and cortisol is normal and there is hepatomegaly, I think of glycogen storage disease. If there was no hepatomegaly, I'll think of the other causes of ketotic hypoglycemia. If there was ketone present, if the cortisol was less than 50 and the growth hormone was less than 10 millimole per liter, in the presence of confirmed hypoglycemia, I'll do STH level. If it was low, so it's have a hypopituitarism problem. If it was high, I have an adrenal insufficiency problem. Hyperinsulinemia newborn, it's a clinical syndrome of pancreatic beta cell dysfunction characterized by failure to suppress insulin secretion in the presence of hypoglycemia. Although it's not that common, but it's the most common cause for persistent hypoglycemia in the newborn period. As we said before, not only an insulin decreases serum glucose, but also suppress the fatty acid release and ketone body synthesis, so it's prevent the brain from alternative fuel source. So it's a serious cause of hypoglycemia that can cause brain damage. The cause of hyperinsulinemia, there's infant of diabetic mother, and it's usually a transient cause resolved in about 48 hours. We have congenital hyperinsulinemia, which we will talk a little bit in about 2 minutes. We have like mutations of the genes encoding on the pancreatic beta cell ATP sensitive potassium channel like ABCC8 and KCNJ11, which encode for the sulfonyl urea receptor 1 and the KIR 6.2 proteins, which we'll talk in about a minute. Secondary causes, like we have syndromes of hyperinsulinemia, like Bickus-Weidman syndrome and other syndromes, perinatal asphyxia or insulin-producing tumors, or even we can induce hyperinsulinemia if we sudden cessation of I'm giving high glucose content, if I sudden stop, there will be a secondary cause to hyperinsulinemia. So what are the diagnostic criteria for hyperinsulinemia? This hypoglycemia is caused by hyperinsulinism. Diagnostic criteria, first criteria is that the glucose requirement to maintain blood glucose above 2.6 to 3 millimole per liter, which equivalent to 45 to 55 milligram per deciliter, I need more than 6 to 8 milligram per kg per minute GIR. In our case, we needed up to 15 milligram per kg per minute to control our blood sugar. That means the laboratory blood glucose is less than 2.6 millimole per liter, which is equivalent to 45 milligram per deciliter. Elevated insulin at the point of hypoglycemia with raised C-peptide, which raised C-peptide is important to diagnose that endogenous insulin, not exogenous insulin. Inappropriately low blood free fatty acid and ketone bodies concentration at the time of hypoglycemia, and of course, the absence of ketonuria. Congenital hyperinsulinemia. This is the beta cell in the pancreas. We will talk about how insulin is released. We have ATP sensitive, the ATP sensitive potassium channel. Main proteins in it are the sulfonylurea receptor and the KR6.2 receptor, which allow the potassium efflux from the cell to outside. And usually it's open, so the potassium efflux causes that the membrane potential is depolarized at -70 millivolt, which closes the voltage gated calcium channel. When glucose enters the cell after utilization in the mitochondria, the ATP to ADP ratio increase. So this causes inhibition of the proteins, the receptors, and the closure of the ATP sensitive potassium channel. This allows the membrane volt to increase from -70 millivolt to -30 millivolt, which opens the voltage gated calcium channel. So calcium enters into the cell. This causes the exocytosis of the insulin and insulin release. So in the next picture, we have here a congenital mutation in the gene. The gene is usually located on 11 chromosome, on the short arm of the 11 chromosome. If I have mutation in the gene, so I have mutation in the receptor proteins. So the channel is blocked, the potassium channel is blocked, so the membrane is always -30 millivolt. So there is always continuous influx of the calcium through the voltage-gated calcium channel, causing continuous insulin release, causing the hypoglycemia. So hyperinsulinism to be caused, we have about 30 to 50% by abnormalities in either gene controlling intracellular metabolic pathways or membrane cation transport. Like we said before, most abnormalities described to date related to genes controlling sulfonylurea receptor and the inward rectifier potassium channel, KIR6.2. These proteins that together form the functional ATP-dependent potassium channel in the beta cell membrane. We have over 40 different mutations have been reported, mostly which are recessively inherited. There's another mutations that cause abnormal activation of the glucose signaling of insulin secretion by altering the enzyme kinetics of glutamate dehydrogenase or glucokinase have been described. Because this abnormality, we don't have a mutation in the potassium sensitive ATP channel, so most of these cases respond to the diazoxide, because the diazoxide acts on the potassium ATP sensitive potassium channel. So if they are normal potassium channels, ATP sensitive potassium channels, so diazoxide here would be a great of value. In our case, diazoxide didn't cause much improvement of our random blood sugar. So finally, we'll talk about short notes about the drug used in the treatment of neonatal hypoglycemia. First one is the diazoxide we talked about, used in hyperinsulinemic hypoglycemia. It opens the potassium, the ATP sensitive potassium channel. So so it's when it opens the channel, it causes potassium efflux. So the membrane potential goes back to -70. So it closes the voltage-gated calcium channel and stop calcium entry and stop the insulin release. It also increases adrenaline secretion and increases gluconeogenesis. Our usual dose, we start with 5 milligram per kg per day, up to 20 milligram per kg per day. It's taken orally every 8 hours. Side effects, we have serious side effect of diazoxide, which is a fluid retention. So it's usually taken with chlorothiazide to avoid the fluid retention. It causes hypertrichosis, hyperuricemia, facial changes, and hypertension. Rarely it causes leukopenia and thrombocytopenia. The chlorothiazide is not taken alone, but it's usually has synergetic effect with diazoxide by acting on non-ATP sensitive potassium channels and avoid the fluid retention side effect of the diazoxide. The dose is about 7 to 10 milligram per kg per day in 2 divided doses. Some of the side effects of chlorothiazide that cause hyponatremia and hypokalemia. The octreotide also it's used in hyperinsulinemic hypoglycemia, which is the drug that gave us marvelous effects in this case. It activates the G proteins coupled rectifier potassium channel, hence inhibiting also the insulin release. The dose is 5 to 20 microgram per kg per day. We can be taken intravenous or subcutaneous, maybe infusion or shots. Side effects, it's cause suppression of the growth hormone, the TSH, ACTH, steatorrhea, abdominal distension, and decrease growth rate. There are some studies about using of nifedipine as a calcium channel blocker. Some cases may have mutations in also not only the ATP potassium channel, but also in the calcium channel. So it may give some effects if we use nifedipine to obstruct, to close the calcium channel and avoid calcium influx, which causes the release of insulin. So we need to know from this case that it's very important if any macrosomic patients with that random blood sugar has to be checked, and if any persistent hypoglycemia and recurrent, we should always think of hyperinsulinemic hypoglycemia. Thank you.
بسم الله الرحمن الرحيم. شكرا يوسف على البرزنتيشن بتاعت الحالة، وهنسمع بقى الدكتورة مها تعليقاتها. ومها أستاذ أطفال ونيوناتولوجي، زميلتي وصديقتي وتلميذتي، كنت مشرفة على الدكتوراه بتاعتها فبعتبرها تلميذتي يعني، بس كنت صغيرة جدا بس كنت مشرفة على الدكتوراه معاها. وأنا سعيدة إن أنا بقدمها، وسعيدة إنها كلنا نكبر واتمنى من الصغيرين في وحدتنا برضو يعرفوا قد ايه فعلا على راي دكتور هشام احنا تعبنا جدا عشان نوصل للمرحله دي، ويكملوا ورانا، ويعني يبقى عندهم الموتيف كده انهم يبقوا كويسين وكبار باذن الله. اتفضلي يا دكتور مها.
بسم الله الرحمن الرحيم. بشكر الدكتوره صفاء على التقديمه الجميله دي، هي اختي الكبيره وحبيبتنا كلنا، مش حبيبتنا بس، هي عارفه. طبعا انا بتوجه بجزيل الشكر للاستاذ دكتور هشام عوض، الاب الروحي بتاع الوحده،